Jeremy Coy is Professor of Forensic Psychiatry at Queen Mary College at the University of London. He's a consultant to the in forensic psychiatry to the East London Forensic Psychiatry Service. He's director of the Forensic Psychiatry Research Unit and has really been looking at a population of more severely disturbed patients with borderline PD, but also more extreme kinds of problems. Here he has a really interesting new data set that I haven't seen that I'm very eager to hear about, which is the National Household Population Study. We're looking forward to learning about this, and I'm sure Jeremy will say a word about this, but there's been an interesting, pretty unique, I guess, countrywide effort in the UK to focus on populations that over here it's very hard to get attention to look at, which has to do with antisocial and overlapping borderline populations. And so I think we have a lot to learn from this data set. So, turn things over to you, Jeremy.
Thank you very much, ladies and gentlemen. I'm going to present a paper rather than an overview. John originally asked me to give a talk about more forensic populations, but I wanted to talk about this particular data set, which I'm particularly au fait with at the moment, I'm particularly interested in. I've had a very interesting trip. I had an interesting experience yesterday. I might have encountered somebody with borderline personality disorder down in the market. I was buying some jewellery for my daughter, and I was sort of bargaining. Once I fixed the price for this lady, who must have been about 60, she asked me where I was from, and I told her, I asked where she was from. She said from Bulgaria originally, and asked me if I had a girlfriend. And some of the ladies are thinking, do all men get up to this when they come away to conferences? And I, to my shame, said, lots actually, but always room for one more, rather hoping that I might bargain her down for some more jewellery. At this point, she began to tell me about her various exploits when she came to this country and how men were mad for her, and I got more information than I really expected. But then she sort of disclosed to me something else. She said, I'm very sorry you lost the war. I thought, I think she's mixed me up, actually. I said, well, actually, we didn't. With a bit of help from yourselves, this country, we won it, actually. No, she said, no, she says, you didn't. She says, very sad. You see, these Americans, they know nothing. And I realised she meant the War of Independence. And I'm going to go back there before we go to one thing we don't know much about, to be honest, is personality disorder. And if I'm honest, over the years I've been coming to the USA to actually learn from people who are much more an expert than myself. And well, this is the sort of frontispiece from a policy document that was circulated in my country in 2003. The notion that personality disorder should no longer be a diagnosis of exclusion. Now, when I first started training, I started training in a large mental hospital, like a state hospital. And we used to admit patients with personality disorder, usually for a very brief period. When I moved to train in the Maudsley Hospital, Centre of Excellence, woe betide me if I admitted a patient with personality disorder under my consultant's care. I was in trouble if I'd actually been on call the night before. And so over the years, personality disorder has been used very much as a way of actually excluding patients. And in forensic practice, you sometimes see patients who clearly have schizophrenia and have been relabeled as personality disorder. So it's very much a policy in my country to actually encourage rather strongly psychiatrists to admit and not exclude patients with personality disorder. I could give another talk. We're very interesting at the moment. There's a lot of money going into personality disorder, but that's very much at the antisocial end, the whole issue about treating or trying to treat patients with the notion of public protection. What I want to talk about today is the epidemiology of borderline personality disorder. Now, in a number of studies, just reviewing very, very crudely, general community studies seem to range quite widely from 0.5 to 3.2. I think 3.2 is really very high. And I'll talk more about it in a moment. Primary care studies say about 6%. Prisoners between 14 to 23%. Psychiatric inpatients, these are from American studies. You would never find 15 to 20% of patients in any UK hospital having personality disorder. It's the National Health Service, it's all free at the point of entry into the system, but it means that you prioritise, you ration care, and our services are primarily, in a hierarchical fashion, devoted primarily to patients with major psychosis. Inpatients with personality disorder, 50%. Actually, if you were to look at inpatients in a UK hospital, virtually all would have borderline personality disorder. Those are the patients that actually get into our hospitals. It may not be necessary in the USA, where these figures come from, but certainly in the UK it would be borderline personality disorder that you see. We know there are 3 studies in 2001 all talk about the treatment seeking of borderline personality disorders, and the Scodel study, the most prevalent Axis 2 disorder in clinical settings. And also high rates, I thought was interesting, in medical as well as psychiatric settings. Bender's study, talking about personality disorder in general, consuming very large quantities of outpatient, inpatient, pharmacological treatment, more so than major depression, with their controls, especially borderline and schizotypal. Mary Zanarini's study, demonstrating that compared to Axis controls, more individual group, couples therapy, self-help, psychiatric hospitalization, medication than the controls. And according to a study, to quote her, borderline patients receive an enormous amount of psychiatric treatment. The thing about community studies is, if you think about much of the research, and one has to say some of the research heard today, these are concentrated, as John Oldham said initially, on more severe cases. They're often institutionalized samples. And there's always the question, are actually these samples biased towards the treatment seekers? For my own work, I mean, I've talked about borderline personality disorder today, but more recently been more interested in spending my time, that's where the money is actually in the UK at the moment, to do research, looking at psychopathy and antisocial. Many of these, the things that we know, certainly about psychopathy, are based on experimental prisoner samples. And indeed, certainly where I work, thinking about the Maudsley Hospital, I only can remember as a junior training there, as a resident, maybe about 1 or 2 borderline personality disorders admitted to that hospital who were male. They were virtually all female and all young. So there's the question, is that really a representative sample? I mean, I published one of my first papers from the Maudsley Hospital on a primarily female borderline sample. So there's little known about the full range. There could be differences. One study which I think is particularly interesting, there is another study looking at a representative sample of a national survey in Australia, which showed, as we all know, that borderline is associated with one or more Axis 1 disorders, loss of days of role functioning in various roles, that is. I thought interesting the increase in physical conditions in that particular group. What I'm going to talk about, I have to put this in context. The survey I'm talking about today, which was carried out in 2000, was one of a series. These are sponsored by the Department of Health. They usually cost £1 or £2 million to carry out. The first was in '94, adults 16 to 64 in private households, in others, resident institutions, homeless adults, adults with psychotic illness, prisoners. That was the first one when I was involved, from being at my forensic background, my interest in personality disorder, children and adolescents, and this one more recently. I once met the Queen in St Bartholomew's Hospital in London. The Queen asked me, has mental illness increased? Is it increasing? I was completely tongue-tied. I didn't know what to say, and somebody started speaking to her, so I was too shy. But I can answer the question now, and the answer, if based on these 2 studies, there's no evidence using exactly the same instruments whatsoever of any increase in any mental disorder. What there has been an enormous increase in, and I suspect it's the same in the USA, is substance misuse. And in the UK, actually, alcohol, enormous increase. The aims of the study, of the survey, was to estimate psychiatric morbidity by category, particular emphasis on the use of services, very much primary care. In the UK, health services are very primary care orientated. That is the first point of entry for many people, apart from in emergencies, into specialist care. And that is the way the government wanted. That is the way it's organised. We're also looking at social disabilities and disadvantage, key associated and lifetime factors. This is no way longitudinal, of course. This is a cross-sectional study, and there was some comparison of the two surveys. It compared the three countries, England, Wales and Scotland, adults between 16 and 74, based on postal code files, and we use ICD-10 mental illness, and I managed to persuade them to use DSM-4 personality disorder. What I want to talk about today is the diagnoses are based on self-report instruments. I'm told you shouldn't be using the word neurotic in the USA. They don't like that word, it's gone. So I'm really talking about affective and anxiety disorder. I should cross that one out. Using an instrument called the clinical interview schedule. When I talk about psychotic disorder, I'm talking about a screening positive for psychosis. We use the SCID-2 screen. People know that instrument. You can actually administer it in a research setting if you want to. You can actually hand it out to your participants, or indeed your patients in a waiting area, and get them to fill it in. And then you ask questions in a different way. So we use the screen, and there were questions to elicit substance misuse. A range of different topics, looking at general health, service use, demographics, education, as you'd expect, accommodation, some life events and social networks and daily living. It is a true two-phase survey, and a two-phase as opposed to a two-stage survey in epidemiology is one where the ones you interview in the second phase are determined by screening instruments in the first phase. Okay? This has major implications for analysing your data. You have to weight your data. You have to include a statistical method where you somehow bump up, increase the numbers of those who don't appear in your first phase. If you think about it, who's most likely to say, if somebody knocks on your door, who's most likely to cooperate? Is it a man or a woman? It's a woman. Somebody older or somebody younger? Somebody older, somebody lower class or higher social class, somebody higher social class. So you actually have to weight your data to increase the numbers. You also have to look at your sampling frame because you'll get clusters in certain areas of certain cities. So there's a procedure of weighting the data. The data I'm talking about are weighted. So you have a sampling frame based on the post office. A KISH grid is a way of getting one person in each household. Computer-assisted interviewing, and they have lay interviewers. The company that do this, they have their own workforce, who are usually graduates. They're usually even middle age, quite a large number are female, and they interview people on a laptop computer, and people fill this in themselves. The study was designed to identify rare disorders, primarily schizophrenia, and I managed to persuade them to put in for the first time ever personality disorder. And so you have a process of having screened people who are positive with your instruments on the laptop computer. You then interview them using standardized instruments. And so you've got, this rather busy chart is just to show you the process. You start off with just under 16,000 addresses, which is supposed to be representative. You find a few houses don't exist or been pulled down or something, and you get just less than 9,000 adults completing the interview. I'm going to talk about this part of the study, but for the second phase, using the screens, you get those who are invited to participate. In terms of the response, it was just under 75%. Interestingly enough, one of the highest things on, probably about the item highest on the political agenda is the health service, a vast amount of taxpayers' money, employing more than, I think, the Red Army. So it's not surprising, and there have been a lot of concern. So the actual success rate was low. It was nearly 75% of people in the previous survey, about 7 or 8 years. And people, why did they say they didn't want to take part? Because we're concerned about our health service. We don't like what the politicians are doing to our health service. But in terms of a response rate, it's good enough. It's an adequate survey, certainly in the first phase. Now, what I want to talk about is this group. Okay, these are data which were published about 2 or 3 months ago in the British Journal of Psychiatry from the second phase, identifying the prevalence of personality disorder in Great Britain. You see, it's much lower, and I could spend an hour or two arguing about Spentorgations, but I do not believe that 1 in 7 of the population of Oslo have got a personality disorder. I think that, in fact, there was no news. This actually was in the newspapers. 1 in 20 of Britain have a personality disorder, which the journalists seem to think was rather high, which is interesting. I mean, what is face value? Is that high? Is that low? Certainly for this audience, they're saying, hey, that's a bit low, that's the lowest ever published. But for the journalists and for the general public in the UK, my goodness me, 1 in 20 people have a personality disorder. So it's worth thinking about. There's a whole issue about sampling, and I think also very importantly, the instruments that you use. What we didn't find in that sample size with any people with histrionic and narcissistic, interestingly enough, despite all the terrible things I've said about Sven's study, we find exactly the same prevalence using that different method. Well, what I'm talking about today are the screen results. I'm talking about this group, the 1.3, and of course if you're using a different method, self-reporting, you've got a very large prevalence. I suppose you would say, in terms of getting a perfect match, and thinking about a screening instrument, not so good. This is those who, if you say the screen says they've got a borderline personality disorder, how many actually turn out to have that? Well, only 14%. Does the screen say that they haven't got it? Well, it's much more accurate. Only 2% don't have it when it says it doesn't have it. If you look at a correlational statistic, it's extremely high. So, and if you look at the individual personality disorders, each personality disorder correlates with the same personality disorder. But you tend to get these sort of results when you talk about something with a low base rate. We did the same thing in prisoners, and the positive predictive value is much, much higher, because the prevalence is much, much higher. That just gives you some statistical idea of the accuracy. So we're talking about a group out of that 8,000 odd of 113 people. When we look at that 113 people, we find their demographic characteristics. We find male and female exactly the same prevalence. They tend to be younger, not surprisingly. No ethnic differences. They tend to be unemployed or economically inactive. They tend to have no qualifications, but we didn't find, surprisingly, I kept asking my statistician, check that, no differences in marital status, but I'll show you something about divorce and separation in a moment. No association with social class. They tend to be in rented accommodation rather than owning their own home, and no urban-rural associations. This rather busy slide, this is the line to look at. The lady was rather elderly, actually, in the market. That might be her there, but you can see there's a dramatic decline. You tend to see there's several personality disorders, slightly higher in the 25 to 34 year, but certainly in the cluster B, the prevalence declines quite dramatically over time. Now, this is a cross-sectional survey, it's not a longitudinal study, so I can't say that's because it's borderline personality disorder burning out. It probably is, whatever borderline personality disorder is. It could be, of course, things like suicide, outward migration from the country, I doubt that. It's most likely to do with the longitudinal process. But, of course, it's a survey, so it's there to generate hypotheses. These There's 113. Essentially what I'm doing here, I could be making it a bit complicated for you comparing with depression, but this is just comparing with the rest of the population, showing in terms of the odds, what you'd expect to say, show that people with BPD are over three times more likely to be separated and divorced. They might be not fitting into the different status of being married or single for the survey, but in terms of having been separated and divorced, the risk is threefold, nearly sixfold admitting to having assaulted or had a fight with somebody in the past 5 years, financial crisis, 7 times the risk of homelessness, nearly 7 times the risk of having been in a children's home, sexual abuse, over 5 times experiencing violence at work, nearly 3 times. It's not worth putting in it's so high, the comorbidity, I didn't even bother to put it in. All axis 1 disorders, as we know, highly comorbid, similarly with axis 2 disorders. Looking at self-reported mental health problems, it's surprising that, well, maybe it's surprising that a third say they haven't considered suicide. Perhaps that's where this talk's going, that maybe there are differences about people with borderline personality disorder in the community. A third said they hadn't considered suicide. Over half saying that their emotional problems are limiting their daily activities. In terms of deliberate self-injury, 28%, only 13%, although it may be the risk is 18-fold compared to the risk of the general population, only 2% saying they've ever been in a psychiatric hospital, only 13%, maybe a lot higher relatively, but only 13% of this sample have actually say they've ever been in a psychiatric hospital. Now, you could say that you could look at this both ways. You say, oh, well, that's the UK, that's the National Health Service. But people like me are being told to exclude them by their bosses. On the other hand, if it's so free, you could be saying it's much easier to get in if you're of low social class, you haven't got much money, than it is in the USA. So I don't know what that means, but you could look at it either way in terms of access to inpatient service. In terms of self-reported physical health, some evidence that they are more physically unwell, somewhat more likely to have seen a GP for their physical health, somewhat more likely to report that they have a long-standing physical illness, to say that their physical health is only fair to poor, that their physical health is limiting their activity, large number of smokers compared to the rest of the population. And quite a number say they have nervous system complaints. They don't just mean migraines, headaches, but actually say they have a neurological condition, which I thought was interesting. In terms of what healthcare are they receiving, what do they report, you can look at this both ways. Only a third or a third. It depends on, is the glass half empty or is the glass half full? But I think for many people thinking about treatment-seeking samples, from which much research is based, of the group in the general population, only a third has seen a doctor for any reason for mental health. Only less than a third are currently on psychotropic medication. And then looking at maybe the risk, the odds of having counselling are tenfold compared to everybody else, but it's about 1 in 5. Similarly, just over 10% receiving current psychotherapy and other forms of community mental health care. So only a relatively small group currently receiving these sort of conditions, apart from perhaps seeing their GP. What I want to just finish with is just looking at the characteristics of those who are seeking treatment. Roughly you could divide them into just slightly over half that were currently receiving some form of treatment. So what I looked at were those who reported seeing a professional for mental health problems over the past 12 months. So it seemed that the majority, if they consulted anybody, they consulted their general practitioner. just over half. And the range that only 9% of people with borderline personality disorder had seen a psychiatrist in the past year. So in fact, it's 56%, which meant that 44% had not seen anybody, any professional, considered anybody professional for mental health problems over the past year, despite receiving that diagnosis. What was different about them? Well, there was no difference what I expected to find, which I expect most people expected, was I'd find there'd be more females when thinking about my Maudsley experience, but that was not the case. What I personally find very interesting, there's a lot of interest in accessing, is that it's disproportionately white. Though I showed earlier that there was no difference in ethnicity, those actually seeking professional help are disproportionately white, and this is what you typically see. If you go to inpatient mental health services in the UK, which I said are primarily aimed at treating people with schizophrenia, you'll see, particularly in areas with ethnic minority populations, a disproportionate number of African Caribbeans diagnosed schizophrenia. There's a large amount of epidemiological research looking at this phenomenon. The incidence of schizophrenia is higher amongst African Caribbeans in the UK. Some people have looked in the Caribbean, where most of the evidence originated from, where it's the same as it is in UK whites. Something to do with migration. That's an aside. But when one looks at personality disorders, exactly the same phenomenon you see in prison-based services. It's disproportionately white prisoners and white subjects who are accessing treatment for personality disorder. There didn't seem to be a difference in the age, or whether their marital status or social class, but certainly those without qualifications who are unemployed were more likely to have accessed some form of professional in the last 12 months. When we looked at the self-reported health problems, those who'd seen a professional were those who had been in a psychiatric hospital. None of the ones who hadn't been in contact with services had ever been in a psychiatric hospital. More likely those who had said they'd attempted suicide. Perhaps it's not surprising, as part of the diagnosis for borderline personality disorder is deliberate self-injury. Perhaps it's unsurprising if you think of it that way. There's no difference about deliberate self-injury. More likely to say their physical health is poor. More likely to say that their activities are limited, but not long-standing physical illness seen at a GP. More likely to have seen, somewhat more likely to have seen a GP for physical complaints. When we looked at social problems, I mentioned a range of social problems. I was a bit surprised actually. I thought maybe the more violent ones, maybe those who've been in care, separated, divorced, experienced violence, problems with police or courts, maybe wouldn't, maybe they'd be in prison or something like that, but no, it seems to be somewhat, not a very large degree, but having been homeless or sexually abused did seem to have some bearing on whether they were in contact with services. No, surprisingly, no significant differences for any comorbid access to disorder. It wasn't the antisocial borderlines or being in prison and not seeing healthcare professionals. It wasn't those who are substance misusing either being more likely or less likely to appear. And it seemed that it was really just one particular area, the main finding of the survey in terms of determining treatment seeking was the Axis 1 comorbidity. What we found was that if you had generalised anxiety disorder or depressive episode, considerably more likely, or if you screen positive on the psychosis screen, far more likely to have accessed treatment over the past year. These were the findings that seemed to be determining seeing professionals for treatment. So to conclude, it seems that borderline personality disorder, as we would expect, is associated, just confirming what everybody has already found, it's associated with considerable burden of care, high levels of social and behavioural problems, comorbidity, and some evidence, not quite as strong as the Australian survey, but generally supporting that, of poor physical health as well. But most importantly, we found that only just over half were actually in contact services. It seemed ethnicity was important, being employed was unemployed was important, gender did not influence treatment seeking, and the treatment seeking, most importantly, is due to comorbid affective anxiety disorders, which we tend to imply is not due to borderline personality disorder. What doesn't happen, people do not go to their doctors and say, please will you treat my borderline personality disorder. You see them because they've cut themselves, or they've taken an overdose, or they have a severe depressive episode. Thank you.